Okay, well, I think we're going to go ahead and get started. I'm Dr. Rachel Pope. I'm a gynecologist at University Hospitals, and I'm part of the gender care team. And I'm very pleased to introduce everyone to Dr. John R. Blosnich. Dr. Blosnich is an associate professor and director of the Center for LGBTQ plus Health Equity in the Suzanne Dworak Peck School of Social Work at the University of Southern California. He's also a part-time research health scientist with the Center for Equity Health Research and Promotion with the VA Pittsburgh Healthcare System. After earning his MPH and PhD in Public Health Sciences from West Virginia University, he completed a postdoctoral research fellowship in suicide prevention with the Center for the Study and Prevention of Suicide at the University of Rochester Medical Center. His research, as you'll hear today, focuses on health equity implications of sexual orientation and gender identity, with specific emphasis on social determinants of health and suicide risk. Having published over 180 articles on these topics, his work has appeared in journals such as JAMA Psychiatry, American Psychologist, and the American Journal of Public Health. Dr. Blosnich has earned several research awards from both the VA and the National Institutes of Health. Most recently, Dr. Blosnich was a 2021 recipient of an NIH Director's New Innovators Award, which supports his efforts to expand research into non-clinical sectors in which adverse social factors and acute life crises can be targeted for upstream suicide prevention. So join me, please, in welcoming Dr. John Blosnich.
Thank you, Dr. Pope. Thanks, everyone. Thanks for the invite to come. Thanks for making the time. Good morning. It's actually still morning there and morning here in Los Angeles. So I will go ahead and get started and do the always dreaded handoff onto sharing my screen, which hopefully is working okay. Um, so today I'm going to be talking about something maybe a little bit different from other talks you've had and focusing more on mortality. Most of my work is in suicide prevention, but my focus from the last, 4 or 5 years has really been in the problems that we face with assuring health equity and health services research for LGBT individuals in the face of not having information about sexual orientation and gender identity. And where this really comes to a head is in our mortality systems, which I hope by the end of this will give you sort of a new fervor for why this information is sort of on a cutting edge and how we could possibly improve those systems. So I want to disclose I have some support from NIH and from VA, that my opinions are my own and don't necessarily reflect those of my institutions or funders. And I do have some photographs and names that I use in this presentation, but they are gathered from publicly available news articles. So there's no, if it's personally identifiable information, it's because it was already in the public domain before this. So I have to start. Most of us who do suicide research, just giving resources from the very beginning, 988, which is the National Lifeline. And then in our time together, wanting to assure that, kind of the main, I guess, gems of this would be that folks are able to summarize disparities in suicidal ideation and attempt that we know of based on sexual orientation and gender identity characteristics, explain challenges around mortality research as it pertains specifically to LGBT individuals, and then describe a couple strategies about inclusive strategies for sexual orientation and gender identity, which I may call SOGI throughout the talk, and how that can be implemented within administrative data resources. So administrative data being a little bit different, maybe a lot different from research data, and then leave you some time for discussion. So I want to start off with some level setting. So sexual orientation is typically thought of as compiled of three constructs: attraction, behavior, and identity. But most importantly, everyone has a sexual orientation. This is not solely meant for people who may identify as lesbian, gay, bisexual, pansexual. Heterosexual people also have a sexual orientation. And so it's probably not unsurprising that everyone also has a gender identity. And gender identity, similarly, is kind of thought of in terms of three constructs of your sex assigned at birth, your gender expression, and of course, your own identity. And of course, gender identity is not a concept that is just relegated for people who may identify as transgender or non-binary or gender non-conforming. Cisgender folks, that is a gender identity. Everyone has a gender identity. And so as one example of that, you can see here, this information on this slide comes from the US Transgender Survey, or USTS. And in 2016, when they did this, the re-up of this survey is coming out. They had a little over, I think, 27,000, maybe 25,000 trans and gender nonconforming people respond to the survey. So it's, I think, still the single largest survey of trans and gender nonconforming people that we have in the United States. But what's interesting in this survey is they let people select all of the, all of the terms in their gender identity option that the respondent felt applied to them. And they had an open text field as well. And you can see here, these are not mutually exclusive, of course. But you can see that folks have a variety of ways in which they describe their gender identity. And that doesn't mean that, any one gender identity is, sort of more salient than the other. It's that people have it just, a diversity of ways of describing this, and they will choose the words that would describe them if given the chance. A lot of times in our epidemiologic surveys, we only let people choose one. So this survey gave a very unique example of what we can learn from folks when they get that opportunity. And importantly, I want to make a very quick plug here that gender identity is not dependent on medical therapeutics. So a person's gender identity is their own, agnostic to the, gender-forming hormones or any gender-affirming surgeries. Now, we often use the abbreviation LGBT. And I want to just kind of hit home a point that sexual orientation and gender identity, they are related, but they are distinct constructs. So you can see here in these two circle graphs, one is for a group of individuals who identify as transgender. So this is their gender identity. And the other circle is for folks who identify as cisgender. And these adults were asked, what is their sexual identity? And so you can see for transgender folks, about 40% of them identified as heterosexual. Then this information comes from the Behavioral Risk Factor Surveillance System. This is a population survey from the CDC. So it just illustrates that because we have information about sexual orientation, it doesn't necessarily mean we have information about anyone's gender identity and vice versa. And this sort of flips the relation between the two again. So this is information from about a little over 11,000 adults who identify as lesbian, gay, and bisexual, and they were asked to describe what their gender identity is. And you can see here, 96% of them identify as cisgender. So again, although we use a shorthand of LGBT all the time on everything, including the Center Right Direct, it's important to underscore that these are related but distinct constructs. And that'll be important when it comes to the data collection part of it. Now, how many people identify as LGBT? So Gallup is who we look to for probably one of the most current estimates in the country. So these are data that Gallup just put out, and you can see the kind of the increase over time since they started asking this question about how individuals identify themselves. And here you can see that they can check as many as can that apply: straight or heterosexual, lesbian, gay, bisexual, or transgender. So in this instance, this question is blending sexual orientation and gender identity together. But what Gallup has come up with most recently is that about 7.6% of the adult population in the US identify as LGBT. And again, you can see that is increasing over time. Now, what do we know about the health of LGBT people? So my specific area is in suicide prevention. And so in suicide prevention, we typically focus on three main phenomena. That is suicidal ideation, suicide attempts, and death by suicide. And so you can see that there are really pronounced disparities for suicidal outcomes for LGBT people. In this review that was done by Travis Salway, you can see that the prevalence of lifetime suicide attempts for heterosexuals across this systematic review and meta-analysis was about 4%. But for sexual minorities, or that would be LGBT people, it's about 17%. And you can see the differences between their team did a really, I think, useful kind of sub-analysis looking at the estimate from probability samples and then an estimate from convenience samples. And then this infographic is not exhaustive by any means, but it's to illustrate that among studies that have focused on transgender populations or gender nonconforming populations, the self-reported prevalence of lifetime suicide attempt is leagues above what we would expect to see in the United States, which is here, and one estimate from the US in green at 3.4%. Most of these surveys, and again, I believe all of the ones that are cited here in this infographic are from convenience-based samples, but that the prevalence of lifetime suicide attempt is just so much higher among trans folks. And so just to hit this home, if it wasn't already evident enough, we know a lot about suicide morbidity. That means like shorthand for ideation and attempt. So this was a review of reviews that I did a few years ago. Every bar is not a study, it's a review paper. So these are, and this is just for, you could see down here, the color code for all the different sort of suicidal phenomena that were the outcomes for these studies. There are a lot of them. I didn't deduplicate all of the reference lists from these studies, but you can see the kind of the TLDR here is that, suicidal ideation and suicide attempt are reported at much greater frequency among LGBT populations than non-LGBT populations. So that leaves us with the question of what do we know about suicide mortality for this group? So there is no vital statistics system in the world that collects sexual orientation and gender identity data. And so if you look at the example from the US specifically, currently about 3 million people die every year in the US, give or take sort of what was happening with COVID. But without SOGI information on these deaths, none of this information can be put to use for public health research, public health prevention. We just cannot answer any questions about mortality if we can't find folks in this level of information. So if we guess that about 7.8% of the population are LGBT, that would be about 234,000 deaths in this group. And that picture down there is of Judy Bradford, who used to be the director of the Fenway Institute. And she kind of very simply and elegantly stated that if you're not counted, you don't count. So again, if we can't find folks, we just cannot answer these questions. And vital statistics they're like vital. And they are both sentinel and benchmark. So our mortality data, they can tell us when there is a problem. But they also lay the groundwork for the benchmarks we need to assess if our public health strategies are actually working to reduce that problem. So it's this eddy of sentinel and benchmark all the time, but it starts with the crucial information we have from our mortality surveillance systems. And so one clear example of this would be the example here of Shanice Wallace. So Shanice Wallace died shortly after giving birth, but she was not alone. So we've known, and these are gathered again from news stories, that Black and African American women's maternal mortality in the US is much higher than white women's. And you can see that here in this graph of information from the CDC. But we would have never known any of this information if we didn't gather race at the time of death to actually know that this was occurring. And so when we know that is occurring, we are now implementing will have been implementing strategies for quite some time of trying to reduce the maternal mortality rates among Black and African American women. So another reason that identity matters, and this is sort of a callback to my life in the VA, is Clay Hunt, who's pictured here. So Clay Hunt died by suicide, and his death came after we'd known for, probably over a decade that the suicide rates among veterans have been rising in the United States, had actually surpassed the general US population, when typically most health outcomes for veterans were lower because of sort of an initial sort of healthy worker or healthy soldier effect, where you have to pass certain benchmarks to, be in the military, which kind of bode for being healthier when you get out. And usually there's sort of a decay to that healthy worker effect. Um, but that veteran suicide rates were climbing was, not good. When they actually met the US population level, really not good. And when they surpassed it, it was sort of, five alarm at that point. Um, but we would never have known any of this information if we did not know who was a veteran and who wasn't at the time of death. So we could actually generate these rates to see the differential between them and then activate policy that, mobilizes resources to then reduce the rates in populations uh, that are indicated. So without any mortality data, no vital statistics on LGBT people, what do we know? It's not that we don't know anything about this population when it comes to suicide mortality. And there are four main ways that folks have tried to learn about this. And that's survey data that have been paired with follow-up mortality data, usually from the National Death Index, which is our gold standard in the country for mortality information. There's medical record data. There's national registry data, which is typically internationally based research because we don't have national registry data in the United States. And then the National Violent Death Reporting System, which is a unique system in the United States, housed at the CDC. And I'll talk a little bit more about that in a second. So I just want to give you a quick, you know, once over of some of these sources and what they say. So if we look at some of the findings from survey data that have been paired with follow-up mortality data, these are large, somewhat well-known population-based surveys, such as the General Social Survey. So you can see in the General Social Survey, results of studies showed that men who have sex with men had no greater risk of suicide than non-MSM, which is one measure of sexual orientation. Remember, there are kind of three ways we think of sexual orientation: attraction, behavior, and identity. And in this survey, it was operationalized with a behavioral measure, so men who have sex with men. However, while there was no difference in MSM, for women who have sex with women, there appeared to be 6 times the risk of suicide death compared to non-women who have sex with women. And the Women's Health Initiative data, however, using the same behavioral metric with a different sample of people, those authors found no greater risk of suicide among women who have sex with women. And then in the National Health and Nutrition Examination Survey, or NHANES, this is both a behavioral measure and an identity measure. LGBT people had twice the risk of all-cause mortality, but there wasn't enough data to actually discern if there was a difference in suicide mortality specifically. So tapping in, you're probably recognizing some of the limitations here as I read through these results. Now we switch over to National Registry data. There's a somewhat clearer picture, but there's a real mixture of magnitude. And again, these are studies that don't, this is not a US population. So you can see here the results from Denmark. So they have a partnership registry in Denmark, and they have the same thing in Sweden. So you can see for same-sex partnered men and women, so same-sex partnered men in the first study between 1990 and 2001 found that they had about 8 times the risk of suicide death. But for women in same-sex partnerships, they had no difference when compared to women who were in opposite-sex partnerships. So you could see the magnitudes change over time with these populations. But again, you're probably seeing some limitations already here indicated on the slide. And so this is some research that we have done in the VA using electronic health record data. So in this slide, the gray line with the axis that goes down just indicates the 10 leading causes of death in the United States at the time that this study was done. This is pre-COVID. So you can see the leading cause of death here is heart disease. The 10th leading cause of death is suicide. This had been the case for a long time prior to COVID. And so in the blue squares are findings for transgender veterans, and the red circles are cisgender veterans. So you can follow them down the leading causes of death and see sort of where they diverge a little bit. But what I want to call your attention to is in this green circle at the end, where suicide was a 10th leading cause of death for cisgender veterans and for the US general population, it was the fourth leading cause of death for transgender veterans. And when we did a different study looking at LGB veterans or lesbian, gay, bisexual veterans, we see somewhat similar pattern, slightly different magnitudes. So for LGB veterans, suicide was the fifth leading cause of death, but for heteros or non-LGB rather, and the general population, suicide was the 10th leading cause of death. Now, you can again probably see and recognize the limitations here. The VA system is not, it's a unique population. Although it's a large population, it is not generalizable to the United States. And the ways that we had to operationalize sexual orientation and gender identity in the electronic health record was very limited. There was no self-identity reports or information in the EHR at the time that we did these studies. So for this study you're looking at right now for LGB veterans, this was headed up by a team who's using natural language processing to identify out of notes and any other sort of structured data veterans or patients who had any indicators that they would be sexual minorities. So things like records saying like her wife or his husband, or actual notes that the provider put in that identified the veteran as, bisexual patient or anything like that would give us an indicator of their sexual orientation. And for the last study for gender identity, for transgender veterans, we had to rely on ICD codes that were related to gender identity disorder, which is how it's still referred to in the ICD, but is now in the DSM referred to as gender dysphoria. So we had to look for essentially gender dysphoria related ICD codes in the electronic health record. And so that gets me to our fourth kind of source, which is MBGRS. So MBGRS research has suggested there's an overrepresentation of LGBT people. In MBGRS is a compilation of people who die from violent means or any sort of investigated death in the United States. But what you can see here is that the information about SOGI in MBGRS is highly limited. So I want to kind of draw your attention here to the last column, the percent of cases that had any sexual orientation and gender identity data in them in each of these studies. And you can see that it's below 25%. Some of them much lower, 16% here for this final study. I often ask my students, would you drive a car if you could only see out of 20% of the windshield? And the answer is not no. The answer is, how badly do you want to get to where you're going? And for health equity researchers, they've been waiting for a very long time to get to a destination in which we could actually discern metrics of mortality for a population for whom we have had decades of research that indicate a lot of health risk and social risk factors that don't bode well for thriving. And so researchers are using whatever data they can to get some of these answers. But again, there are a lot of limitations with all of these different resources, which I've kind of summarized here for everybody. That essentially these methods are not real surveillance, especially with survey and registry data that you got to wait a long time to get results from them. And that's not public health surveillance. That's if I had to tell you, get back to me in 10 years and I'll let you know what the leading cause of death is in your community, you probably wouldn't be too happy with that news. There are a multitude of ways. Again, I kind of summarize quickly how SOGI has been operationalized differentially across these different research databases. Importantly, the identity captured in these data sources may not be the identity at the time of death. We know that sexual orientation and gender identity develop across the lifespan, especially for registry. Sorry, single folks, but you're completely left out of registry data. And then, of course, for EHR and MBGRS, missing data are a massive limitation. And that's where we sort of focused our efforts that I'll talk about in a little bit. We recently conducted a systematic review of mortality studies for sexual and gender minority populations. I'm just quickly summarizing them here. And so these are 11 studies I picked out specifically focusing or reporting on suicide mortality for sexual minorities. So this is not including necessarily gender minority individuals. You can see that in this grid of the study quality versus the mortality findings, that there seems to be a definite pattern that the study quality is relatively good, but there's sort of a greater, the studies that have are indicating a greater prevalence of suicide mortality for sexual minorities, there are not as many of them as some that sort of indicate differences in some groups. And this category of differences in some groups means that the study didn't report it in aggregate. Or if they did report results in aggregate, they also reported results specifically for either gay men or lesbian and gay women or bisexual men or bisexual women. And some differences emerged for those groups, while other groups did not have any differences in them. And very few found no difference whatsoever. And so really quickly, a similar thing looking at the evidence for gender minorities, you can see here that the pattern of evidence is a little clearer for that group in terms of showing greater risk of suicide mortality compared to cisgender or non-transgender comparators. So what can be done in the face of all of this? And so one of the projects I've been working on for quite some time, which was started by Ann Haas and Andy Lane back in May of 2014, um, was around trying to figure out how can we improve information about SOGI at the time of death. And so at this meeting, this was folks from the VA, from the CDC, from the National Association of Medical Examiners, a lot of folks around a table who know a lot about mortality information. And essentially, they were thinking that death investigators, so medical legal death investigators, are probably an audience amenable to this because they are at the ground level, which I'll explain in a second, of how we get this information into public health data sets. So essentially, the idea was to develop a protocol about how to get SOGI data in the field to train these MDIs or medical legal death investigators, medical examiners, and coroners on how to use that. They implement this in the field, it gets into their reports, which then gets into the National Violent Death Reporting System. So if folks don't know what death investigation is, it is probably one of the hardest jobs on earth, from what I can tell of shadowing many death investigators here in Los Angeles County. They report to the scene after being summoned by law enforcement. And their job is to document the scene and the body and to gather evidence that goes back to the coroner medical examiner when and if there's an autopsy performed. They also interview informants on the scene, or they follow up with next of kin. This is a conversation. They are not a survey takers. They're not performing a psychological autopsy either. They are trying to get and prioritize information that they need to gather in a very short amount of time. Because you imagine these conversations with the next of kin and with folks on the scene are very difficult. And just to underscore, this is a really underappreciated profession, both for just the intensity of the work, but also how foundational it is to public health. So kind of the adage of you want to see how the sausage is made. They are literally how information get into the National Violent Death Reporting System. So NVDRS gets information from four critical sources. So one is law enforcement reports. The second is death certificates. The third is medical examiner and coroner reports. And then the fourth is toxicology. And so there's an abstractor who may have the second hardest job on earth who has to read this information, and they develop a summary that then goes into, and they code this information that goes into the National Violent Death Reporting System. But in my opinion, the most information that is getting around the context of the person and the situation comes from the medical examiner and coroner reports here, which is why death investigation is so we view it as such a cornerstone for this. So we developed this training for death investigators. For 90 minutes, we go over some didactics, we do some case discussions, and then as time allows, we do some role play so they can get some experience actually verbalizing this question in the context of a mocked up interview with a survivor of loss. And so what do we know? And some of this limited information we got from our feasibility pilots is that most of them had an investigation in which they suspected the decedent was LGBT. But over half of them did not ask about the sexual orientation of the decedent, and 55% of them didn't ask about the decedent's gender identity. And you can see here at the bottom, the pre-training and post-training, very kind of public health 101, very quick in and out, before the training, after the training, showing at least some, intention and some sort of, confidence that they can actually do this in the field. And when we interviewed some of the trainees about 6 months after the training, we still identified some challenges that were coming up for them. Out of the things that were positive, they're confident they can ask these questions. These groups have a very hard job to do, but asking difficult questions is the job. So basically, the training told them, they were like, you just need to explain to me what these concepts are, and I'll figure out. I know I can put this in my conversation. But a couple of the other things that came up as perennial challenges, and this, is involved in a lot of the data gather process for this group, regardless of whether it's sexual orientation or gender identity, or it's, factors around substance use, if it's an overdose case, is that there's, the informant can be in shock sometimes. So how do you get this information from someone who may not be thinking clearly? And then sort of the relevance to the cause of death is a little bit of a barrier here where they're really honed in on the things that could be involved in the death. And whether SOGI is a factor in that, we would never know unless we asked, which is what we tell them. But it's important to underscore again that everybody has this. This is not, everybody has SOGI. This is not just for individuals who are LGBT. So in terms of death investigation, that's what we're hoping will improve this missingness issue that's in the MVDRS that can then get us some better information around suicide mortality. MVDRS also includes homicide deaths. Again, it's all violent deaths. But what else can be done? And this information might be a little bit closer to home for folks who are in hospital settings. And I want to talk a little bit about administrative data versus research data. So in my opinion, what more can be done is really around what we can do with our administrative data sets. There's an increasing use of SOGI measures in federal health surveillance. So I showed you some information from the behavioral risk factor surveillance system, the National Survey of Drug Use and Health, NHANES, of course. So all of these big public health surveys that we do are getting are more frequently using sexual orientation and gender identity items, more so sexual orientation than gender identity. Sexual orientation came onto the scene a little bit earlier, but they are also now catching up with employing more gender identity questions in the surveys as well. But that's research data. It's not administrative data. And so when we think of administrative data, it's really not a sample, it's a universe. So this would be all users in a system, for example, whereas research relies on sampling. Of course, our gold standard would be some sort of probability-based sampling method to give us some sort of representative results at the end. Now, for administrative data, the information that's being gathered in these databases are usually for process. So this is record keeping, billing, volume, visits, number of services utilized. And for research, the purpose is really around creating generalizable knowledge. In administrative data, the measures are limited to those business and operations processes because the administrative data serves the purpose of the organization or whatever sort of service is being delivered. And research, we can choose. Researchers choose all the time what sort of measures they want to use in their data collection instruments, what sort of scales. And lastly, administrative data, they're generally longitudinal by nature because they're just running in the background, collecting this information on users in a system. In research, they have to be longitudinal by design. And the incentives to keep people in either one of them will be a point that I'll talk about in a little bit about how you actually keep folks in a system or kind of keep them long enough to keep getting data from them. And of course, those motivations are different for administrative versus research purposes. But I mean, administrative data are all around us. They're in education, they're in law, they're in supportive housing, they're in social services or human service agencies, they're in medical systems, and we just talked about, some of the administrative data that's involved in death, because death is an administrative process among a lot of things that it is. Um, but there have been a lot of innovations made in electronic health records. Um, I want to illustrate that to you all, just one example of that. So you can see here for FQHCs, they were required to gather SOGI data. Um, by policy. And so when the first study was done in 2016 of these data, and you can see here this sample of about 1,300 FQHCs, you're seeing something that's probably very reminiscent of what was happening in the MVDRS data set. About 63% of them were missing, patients were missing information about gender identity. 77% were missing information about sexual orientation. Now, flash forward to 2021, and here's a follow-up study of those almost same thing, almost the same number of FQHCs here. But you can see that the missingness has gone down substantially. So I'll flip back again just so you can see what was missing in 2016 versus what researchers found that was missing in 2021 among folks. So in my opinion, that is a massive gain in terms of these data being completed and sort of speaking against these myths that, oh, you can't ask these types of questions in a clinical encounter. Patients won't understand these questions. Patients won't answer these questions. I'm not saying it's not true. There might be some patients who don't understand them. There might be some patients who refuse to answer them. But by and large, it's not the majority of folks. Um, so sort of a lot of these, what I consider straw man arguments about not using this information or not using these measures in administrative data um, are, don't hold much weight, especially when we see this information here, that the missingness is not going up. It didn't stay static. It's actually reducing over time. Systems learn how to implement these data collection techniques and these captures. And folks are becoming generally just more and more aware of and comfortable with answering questions about their sexual orientation and gender identity. And the other thing that we can do when we actually have these measures implemented in administrative data is that we can look at things of more than just risk factors. So this is my last example for you all. And you can see here, this is information from the VA, again, of a study we did looking at VA's universal screen for housing instability. So in the blue here, you can see that transgender veterans much more likely to report housing instability or have a positive screen for housing instability compared to non-transgender veterans here in green. So you can see the difference here. So one more risk factor. We know a lot about risk factors. We know that housing instability and homelessness has been an issue for trans populations for a very long time. So detecting it in EHR, not necessarily all that surprising, right? But what we can do in EHR is we can actually begin to look at outcomes and intervention. And that's the most important thing I think that administrative data can give us. So in this very busy slide with VA speak, so if any of you have ever worked with the VA, you know a day without an acronym or an abbreviation would be like a day without breathing in the VA. So I have all of them defined here at the bottom. But these indicate supportive housing programs that the VA offers to veterans or patients who have a positive screen or indicate having housing instability. And you can see in the blue bars and everything denoted with a star, transgender veterans were much more likely to be utilizing these permanent supportive housing programs in VA, which is a good news story that you would at least think from a health equity standpoint, if we're seeing a disparity in a problem, we better see a disparity in the utilization of services to rectify that problem, right? So again, having the ability to look at this information on outcome and intervention is so critically important, but it's really only enabled when we have those administrative data that can identify the marginalized and minoritized groups that we want to look at for health equity research. And then kind of, dream projects here. The National Syndromic Surveillance Program is run by the CDC. It's one source of information nationwide for how we surveil suicide attempts that make it to an emergency department. And you can see here in this map, by and large, most counties, most jurisdictions are participating in NSSP. They're giving their data over to NSSP for syndromic surveillance. And so we could actually get this in real time. But again, the problem is most EHR systems are not gathering SOGI data, or if they do have those fields, they are voluntary or they're kind of hidden away in a field somewhere else that a savvy provider would have to find to implement with a patient. But I want to end on some cautionary tales. I don't want to be too Pollyanna about how we rethink administrative data sets. So administrative data sets, they're tied to a service. They're tied to some sort of deliverable, typically that a utilizer is getting, whether it be healthcare, whether it be food stamps. There's something that person's signing up to get, and we're getting administrative data from them. But by gathering this information from the person, we don't know, and this could increase their fears of discrimination and outing. And that visibility has a cost for minoritized groups. We can clearly see from NVGRS example, a Field of Dreams effect. So basically, if you're familiar with the movie from the 80s, the kind of voice from the sky said, if you build it, they will come. Not so much for administrative data. So we need to make sure that the gatekeepers of the data are trained in how to actually implement SOGI measures. Just because we build a field doesn't mean that it's going to be populated until we indicate to providers and to folks how they can get that information into those fields and how to ask the end users that information. And then lastly, sort of more of a 30,000-foot level is whether this information is just reifying social constructions that are problematic. So for instance, the American Medical Association has relatively recently recommended removing sex from the public form of the birth certificate. And this sort of feeds into a general theme through health equity research, is that the research is often misconstrued as someone's identity being a cause of a negative outcome, when really the fundamental causes are things like sexism, racism, transphobia, homophobia, but those are the things we don't measure. We pick them up because they are being indicated through someone's identity who is experiencing those things. So there's a risk of folks sort of pathologizing identity all over again because it's what we can get, and we're not getting at those fundamental causes. But I want to end here on just, I want to underscore the importance, because without this information, without SOGI information, we really can't adequately or accurately measure the ultimate burden of risk and disease, which in my opinion is mortality. We can't estimate service utilization. We can't estimate clinical effectiveness because we can't find users of service programs, which means we can't direct resources. We can't evaluate our interventions at scale. And ultimately, we cannot hold systems accountable if we don't ultimately have these data to use. So I'll end there. Thank you all for your time and attention, and I think we'll have plenty of time for questions.
Thank you so much. And I know I echo others in saying thank you for this informative talk. And it's been really thought-provoking. And like Dr. Blosnich says, we had some time for questions. So I can open it up now.
So maybe I'll ask the first question, and also a reminder for, I think, everyone, attendees will have to type their question in the Q&A box. And if they want to submit their questions anonymously, they can do that too. Otherwise, I think it'll be public. So thank you, John, for this fantastic presentation. My first, you mentioned some of the challenges around, I guess, research or identifying people to report some of these, participate in some of these surveys. Means, I think, are there any specific or specialized research methods where we can reach this hard to reach population, for lack of a better word? I don't know, is there some, or what are the, I guess, recent progresses, or if any recent progress been made in this area?
Yeah, so one of the questions on folks that folks usually get is like, how do we best ask these questions? Now, oversampling is not yet possible for this group, right? So usually if we have a big survey, we would try to do some sort of method of oversampling for groups that are underrepresented. Unfortunately, and we usually do that by knowing some sort of population benchmark from a sampling unit or a sampling jurisdiction to know that. But we don't have any of those metrics for sexual orientation and gender identity. So oversampling is a bit difficult to do, or it's a bit fraught, I'll say. Um, but when it comes to which kind of questions should we ask, because if you look at the surveys out there, there's a lot of ways that people ask this question, right? I mean, the slide I showed for Gallup mashed them all together. For the BRFSS, they asked them separately, folks who have or were assigned male sex at birth versus people who are assigned female sex at birth. Um, so there's a multitude of ways that people do this. Now, the Institute of Medicine, I'm blanking on what their new name is, but they came out with a document a few years ago to help sort of offer some guidance on how to ask those questions. I will say it sort of came with a bit of a mixed response from the field. So I think that the science around asking these questions is still maybe a bit of an evolving area, but I think we do have a pretty solid grounding because we've had questions asked in a very different way across many different platforms for at least a few years. And I think the resounding byline there is that most people are answering these questions. They're not coming back from surveys with, 40% completion. Like these are mostly being answered by folks who are asking these questions. So, I think the next steps in this are ways that researchers can, develop ways to harmonize data, which I think is a big push for folks now that we kind of living in this era of a lot of data, right? But how do we make those data? Are there ways to make those data talk with each other that could maximize our ability to find groups that are kind of low base rate in the population?
Thank you. There was a question in the Q&A, but there are a few questions in the Q&A.
Sam, I can't see them for some reason.
John, can you see them?
I can see them. I can read
Here
them.
it is. Oh,
Okay.
never mind. I'm looking in the
Okay,
wrong
got it.
box. Sorry.
Okay, thank you.
Okay, so even if we gain access to comprehensive health data, including SOGI information that can clearly demonstrate associations with health disparities in the LGBTQ plus community, will this data meaningfully contribute to preventing anti-LGBTQ plus legislation at the state and federal levels?
Oh, the times we live in, right?
Loaded question there.
I, you know, uh, so my perspective is, and I'm going to have some real talk with folks. No, I don't, because it has become a political issue, and in my opinion, political decisions are not always based on fact these days. Um, so that is just the unfortunate reality I think that we are living through. Um, but I still think that it is important to do, because I think that that last slide that I showed in that last square was holding systems accountable, and that includes holding policymakers accountable for the decisions that they make or that they think that they're making on behalf of their constituents. That we need to have evidence that every decision has a consequence. And if we don't document that consequence, then the folks think that it's just fine and dandy to keep going with it. So while it may not be an immediate, again, this is all my opinion, and while it may not be an immediate halt um, to some of some of this sort of kind of culture war policy that we see going on, um, I think from a public health standpoint, it is very important to still document um, to determine the association between, the laws that are being passed and then the potential association that they have with individual lives on the ground.
Yeah, that makes sense. Another question here is how much is changes in central administration over time a hurdle in building universal buy-in for collecting SOGI data at a federal level?
I don't know, to be perfectly honest with you, because the information that CDC has been gathering sexual orientation and gender identity, in the behavioral risk factor surveillance system. We'll use that. I know that data set the best. So that is the biggest survey that we do in this country. It's also the one we've been doing the longest. It started, I think, in '84, maybe early '80s, we'll say. Um, '84 was a great year. I mean, Cyndi Lauper's She's So Unusual came out that year. Great. But that survey annually at this point, we get about 400, between 400 and 500,000 respondents to that survey. So it is a massive surveillance survey that we do, and we do it every single year. Now there's a core survey and there are optional modules. And since 2014, the SOGI module has always been optional. But at this point, I mean, over 30 states are using that. And it's a mixture of states. I can tell you, some states you think would never use it, actually do use it. And some states you think would never use it, haven't used it. But there's a wide array of states that use it. And this has been going on again since 2014. So all through these political changes we've had in the government, federal government since then, the National Survey of Drug Use and Health actually unrolled their SOGI data maybe around the same time, a couple years later, and it's continuing to do that. So some of these public health measures, I think, are, and I don't want to jinx them, but are a bit impervious to changes in administration. Because at the end of the day, it should be about the work. It's the work of the nation's health. And that should be something that cuts across any sort of political belief that folks may have. So my long-winded answer that I will summarize shortly is that I personally don't know that changes in administration at the federal level have affected this as much as we thought that it would. Thankfully, this is a good example, I think, of inertia, and these surveys just keep going with the questions that they have.
Mhm. I have another couple questions here. This is from Dr. Anna Maria Hibbs. She's asking, do you see geographic differences in resistance from patients or physicians in documenting SOGI by state or even urban versus rural? And could this bias inferences from administrative data sets?
I think that's an excellent question. Off the top of my head, I don't know about responses by state or by urban and rural. I want to be hopeful that someone out there has studied that information. I've been a part of studies that just generally looked at missingness or refusal to ask. And for us, it was specifically looking at veteran status. So were veterans more or less likely to answer these questions? The spoiler alert is that they're not. They're the same, if not more so. But by these very specific characteristics that we know have gained a little bit more polarization, given how the country's been going in the last few years, there's a chance, I don't know, it'd be an interesting hypothesis to test.
Okay, this is from an anonymous attendee. They say, I will be graduating with my MPH degree next spring and currently work in pathology research, which is not focused on LGBTQ plus issues. As a member of the LGBTQ plus community, how can I leverage my skills and expertise to make a meaningful impact for my community?
I mean, there's any number of ways I think that folks can get involved. And I think that being in research, again, is critically important. But I think from a researcher standpoint, you really have to, interrogate why you do what you do and why you want to do what you do. I'm sorry to wax like this philosophic at the end, but a lot of people ask me, they're like, how can you work in suicide for this long? I think I've been in the field now for a little over 15 years. And I say it's because, yeah, I'll study this till the doors fall off. But I know if I reach a point where I can't do it, I will do something else. But for me, it was, a lot of people survive loss. A lot of people have personal experiences of, you know, um, their own survivor stories in this. And it's really tough work. Um, but I think it's important. And at the end of the day, that's in my core, it's what I hold to be important. Um, and that's what I choose to use my skills for. And I think for students or trainees out there, having a very similar, you know, path to finding out where you want to sit, where you want to be in advocacy, because advocacy includes a lot of people. I knew, for instance, I was never a person to stand up in front of any sort of legislative body at all. I'm a behind the scenes person. Tell me what you need to know. I will get the information. I will do the studies, and I will give you the rigorous, these are what the data say. The data are what they are. I'll give you the answer at the end of the day, or one answer at the end of the day. But that's where I found my role in this, for health equity advocacy. And so I'd encourage anyone out there to kind of think through that too, because there's a lot of places that, you can fit in. This is a massive, massive undertaking. Health equity is probably one of the biggest elements of unfinished business in this country. So I hope this anonymous attendee keeps it up. Please do.
Thank you. We have about 5 more minutes if anyone has any additional questions. Keep the Q&A open here.
Well, given I don't have to type as a panelist, I think I'll just ask another question. And sorry if I missed it in your presentation. Do we have, I think a lot of the data here was on young adults or, adult population. Do we know, or do we have the same amount of information or data for pediatric population, given, I guess, they are, they have some added risk as well. And if we take the context of suicide, adults' rate of suicides are, as I understand, are going up. So do we have the breakdown by, let's say, ages?
For general population, for age breakdown, not including SOGI information, well, we do, right, for those deaths. But we don't have mortality data, of course, for young LGBT people who die from any cause whatsoever. In terms of morbidity measures, so ideation and attempt, we have a lot of information from the Youth Risk Behavior Survey, or YRBS, which is another CDC health surveillance project that increasingly includes measures of sexual orientation and gender identity. So there have been a lot of studies in the last, I'm going to say like 10 years or so, that have been able to use those data. And it initially started with state jurisdictions that were including SOGI measures, but now whole states now are using that measure. And then when it comes to mortality data, unfortunately, we don't. I serve on the LA County Child and Adolescent Suicide Review Team, where we review adolescent suicide cases, because we're such a big 10 million people in LA. We have more adolescent suicides than we can review. But in those reviews, we learn things about the decedent, and including information that we don't necessarily get from the medical examiner or coroner's report. So, hopefully that information again feeds into MEDRS. We can get some better signals from the data, more complete information.
Thanks.
Mm-hmm.
Looks like that may be everything. Anybody in the last 60 seconds or so?
Going once, going twice.
Well, I really appreciate your time and your talk today. I think, the take home point of it all is, if you're not counted, you don't count. I thought that's a really poignant quote that you included, and really urges us to try to make these systems better, especially to address health inequities that we know are present for this population. So we really appreciate you taking your time and your expertise and sharing that with us today. We wish this could be in person, but this is the next best thing. Please let us know if you're ever in Cleveland, and we would be happy to host you for more conversations in this area. And really thank everybody who attended the talk today. If you have any follow-up questions, please feel free to reach out. And otherwise, we thank you for your time.
Great. Thank you all.
Thank you. Thanks, Rachel.